I'm Darius Moshfeghi. I'm Chief of Retina at the Byers Eye Institute here at Stanford University, and it's my pleasure to be joined by Derek Ben Amarongan at Humana, Vice President and Medical Officer. We're going to be speaking on minimizing the burden of prior authorization through actionable strategies and improved communication. And Derek, this is absolutely key. As we spoke about in our last segment on managing patients with macular degeneration, one of the key components is deciding on a cost-effective treatment strategy, which is becoming ever more important in today's healthcare system. Can you go over why we need prior authorizations and what this is actually doing to improve our patient healthcare and for us not to view it as a burden as healthcare providers?
Certainly, Darius, and I am completely 100% empathetic with the clinician in the office who has to deal with these administrative processes, and I know that they are typically perceived as burdensome, but there really is a rationale behind them other than, as I think most physicians believe, to control costs. Certainly cost control is a component of that, and I think we'll talk about that. But I want to point out that prior authorization differs from step therapy in a very important way. Clinical information, as the term implies, is collected before the benefits are approved. And really, the purpose of this is to make sure that the drug or the treatment, which typically is going to be one that is expensive and may also have some very significant safety issues, is being used based on the clinical trial data, the FDA label, and any other really critical inclusion or exclusion criteria that came out in the pivotal trials. That means that the drug or the treatment is really going to be targeted at the population that is most likely to benefit. The objective here really is to make sure that we're aligning the coverage with the optimal treatment, both from a clinical and a cost standpoint, to get the best outcome. The best outcome being, as you mentioned a moment ago, cost effectiveness, which really is sort of that interaction between clinical performance and cost of the treatment.
So, which brings us back to the physicians, okay? So, when a patient comes into my office, we don't know how long they've had this disease. All we know is that we want to get the treatment on board pretty quickly because we know that untreated, this can lead to legal blindness within a very short period of time. And so we have some things at our hand which we can deploy. One is we have samples in our offices from the various pharmaceutical companies, but we don't have a lot of those. And then, of course, we have the off-label medication, which is the bevacizumab, which is relatively inexpensive and essentially very similar in profile with respect to outcomes. Bevacizumab, when administered on a monthly basis, gives you outcomes that are very similar to the label indications for ranibizumab and aflibercept. You just really can't stretch it out as long. And why do I bring up bevacizumab? Because it's delivered in a much higher volume typically than what we use for these other medications, and we're able to buy it essentially in bulk and then get a volume discount by taking that volume. And so you can get a dose for around anywhere between $35 to $70, depending on where you prep it, versus the commercially available medications can run you anywhere between $1,500 and $1,900. Now, after tax, title, and license, your $50 to $70 may be higher, but it's something that you can use and deploy right away in the clinic and have less concern that you're going to be putting this onerous burden on your patient, and still at the same time feel very confident that you're minimizing any risk of vision loss. So what does the evidence state about which dose and which drug? And here I said that the verdict is unequivocal. That's not exactly the case. I believe that when you're looking at, if you're going to deploy a monthly dosing regimen, I think all of the medications are equally efficacious. It's only when you start to stretch out the dosing interval that you really start to see separation. And that's important for the total care of the patient because, as I mentioned previously, we're talking about bringing a patient in sometimes for injections in both eyes on a monthly basis. You may be losing a half day for both the patient and their care provider twice a month. I'm not a big believer in same-day simultaneous bilateral injections because of the risk of infection. But the other concern with doing these heavy burden of injections is that we know that there's a very fixed risk of infection associated with each injection. It's about 1 in 10,000 per injection. Over time, those add up. I've had patients with 200 injections in each eye. So that's a lot of injections, and your risk goes up over time. And so over time, what we're hoping to get to is a longer treatment interval between injections, both from a societal cost, from the patient's own experience cost, from the total cost, and then ultimately, we want to be able to feel that we're giving the patient a medication that is safe and effective. So Derek, one of the things that kind of serves as an impediment when we're trying to get authorization for a series of injections, and ideally for the longest period of time so we don't have to keep filling out this paperwork, is that doctors aren't really good at documentation. Let's just be straightforward and honest about it. So as a guy who's on the other side of this, can you kind of walk us through this?
Sure, Darius. And again, I am very empathetic to that. You know, my experience over many years has been that the practices that do these kinds of services routinely, such as ophthalmology groups, such as retina specialists, and also in other specialties such as gastroenterology, they typically have a system that works well for them, and that system usually involves a select group of people who do these authorizations on a daily basis. In other words, they know the paperwork, they know what's required, they make sure all the boxes are checked. On the health plan side, we're really looking for, as I said, documentation of the criteria that match the FDA approval and also line up with the clinical trial information. And when I say documentation, I would say most plans are usually just looking for physician attestation, not faxed medical records or scanned pages from the chart. We want to keep the process as minimally burdensome as possible because it's an administrative issue for the health plans as well. You know, probably one of the biggest challenges we have is one that in many respects is very simple. It's really very much, for want of a nail, the shoe is lost. I can't tell you how many times we get requests and we're missing very basic information such as the ICD-10 code, the patient's first name, a birth date, a member ID number. It sounds almost foolish in terms of the simplicity, and yet that information is absolutely essential before we can even begin to put that record into the system. And so attention to those details is really, really important. And this is where the practices who do this in an organized, systemic way, in other words, there are designated people in the practices who handle these, that's where they become very successful in terms of getting this information in. The vast majority of payers, in fact, I would hazard a guess that virtually all payers now prefer that these be submitted electronically. And if we receive an electronic request, if all of the criteria are met, that request should be approved literally within the same business day, if not within, literally hours or minutes of receiving it. The biggest challenge is verifying coverage. In other words, making sure that in fact this is an eligible member and a network physician. And again, that all comes back to making sure all of that information in terms of member ID, in terms of all of the relevant dates and so on, is included in the initial request. As you see on the next slide, one of the things that we're also very much focused on, especially when you're talking about sequential therapy or long-term therapy, is what is the treatment plan? What has the patient received up until this point? What is the expected treatment going forward? And this typically doesn't have to be anything extensive or incredibly detailed, but there are many, many drugs which are meant to be used first line, many drugs which are meant to be used after another drug. Some drugs are meant to be used in combination, some are monotherapy. And so you begin to understand that that information is really important if we're going to be able to properly evaluate the request and make sure that, as I've said several times, it lines up with the FDA information and all of the critical information from the clinical trials.
Which brings us back to the physician, okay? So when we're sitting here and we are contacting, a medical officer at one of these services for a patient with a new diagnosis of macular degeneration. And this has improved a lot as their sophistication about the diseases that require anti-VEGF therapy has improved over this last decade. We often have to explain to them the difference between continuous versus variable dosing, because there's costs associated with both. On the continuous dosing, like this metronome here that's going back and forth, we're just injecting no matter what. If you have fluid, you're getting treated. You don't have fluid, you're getting treated. The only thing that's different is the dosing interval. Because of the fact that we're treating no matter what, the insurance company or the payer or whatever the group is making a savings because of the arcane way we get paid, is that we're not doing an evaluation of the patient. We can't charge for the evaluation. We can't charge for the study. You're really only paying for the injection and the medication, which is a win for the payer, but they're losing out on the other hand on the frequency of the injection. Now, the other side of this is variable dosing, and there's really two main forms. One is shown here, where you see the syringes and the OCT findings. And the OCT is basically, I like to think of the difference between an OCT and a photograph. As a photograph shows you the retina, and it's like looking at a birthday cake and it says happy birthday, okay? That's a photograph. On an OCT, you're looking at the layers of frosting within the slice of cake, okay? And it shows you how thick the cake is. And so when the cake is really thin, we don't give them the needle. When it's really thick, we go ahead and we give them the injection. That's what we call PRN therapy. However, there's a variation of PRN therapy that's quite innovative, which is on the next slide, and that's called treat and extend. And on treat and extend, retina specialists like this because they feel like they're making decisions, and they also get a bill for the evaluation and the OCT. And so what happens is that they bring the patient in, and then they look at the patient and they say, at time zero, we're going to treat you. And then we're going to bring you back in 4 weeks, and we're going to do a full exam, including an OCT. And if there's no fluid, we're going to go ahead and treat you and extend you out to 5 weeks. They're going to repeat that whole process. If there's no fluid, we're going to repeat you out to 6 weeks. They keep extending until the day comes that there's actually fluid. So let's say at 9 weeks, you came in and finally you had fluids. So what they would do is they'd say, we're going to inject you, and now we're going to bring you back at 7 weeks. And they go back a little bit before where you failed. And then they'll bring you back to 8 weeks, and they say, 8 weeks is the time where there's never any fluid. At that point, treat and extend becomes essentially a fixed dosing interval. We know when you fail. You fail at 9 weeks, so we're never going to bring you back at 9 weeks. We're always just going to go ahead and treat you at 8 weeks. So it takes a little longer to get into your fixed dosing regimen, but we often hear this term personalized medicine. This is kind of a personalized, non-continuous dosing regimen for that patient, which ultimately ends up in this sort of continuous dosing regimen. This is kind of hard to explain to people who aren't sophisticated in the ways of the retina world. Fortunately, as I noted earlier, we've been doing this for a decade, and so the people that we're dealing with are highly sophisticated as to what's going on, and they have their own cost-benefit analysis of how they want us to proceed in their patient care population. That applies to both medications as well as dosing regimens. And sometimes we can, make a strong argument, this particular patient is monocular, meaning they only have vision and they're at a low level. And that's why I want to go with a more intensive therapy. And they get that, they're not ogres or, bad people trying to work against us. They understand they're going to lose more money with a patient who isn't seeing, in other areas of their healthcare system. And so it's worthwhile to have this discussion and go ahead and educate someone. 20 minutes educating someone is a lifetime of benefit as far as dealing with that person in the future on the payer side. So moving on, how do we improve this? It's just documentation, which means, taking the time. List the diagnosis, note the natural history, note your OCT findings, and why you think, based on this visual acuity level and this patient's age and these findings, what you're going to do. And importantly, go ahead and note the patient's symptoms. We have such great technology today that we're often able to find asymptomatic patients with disease that's at a subclinical level that we're not treating yet. And oftentimes we don't want to start treating those patients yet until they become symptomatic and have a decrease in vision. And all of this is important to note. So finally, I guess, we have to have this discussion back and forth. And how can we improve our communication, both with the patient, with the physician, and then finally, our third and very integral party, which is the payer, who's going to be healing with us and the patient, for a long period of time, hopefully. So, Derek, is there anything that you want to add to this discussion and how we can go about improving communication?
Well, I think you've already listed a lot of great points, Darius. The things I would add, as you see on this slide, is, as I said a moment ago, use the online option if at all possible. We still have some practices and some physicians who insist on faxing, but a fax is a piece of paper, and a piece of paper is much more difficult to process and handle than an electronic communication. It just slows things down. And of course, in this scenario, as you pointed out earlier, Darius, speed is important. Doing things efficiently is important. As I said a moment ago, make sure we have all the relevant ID information. I mean, it sounds so simple, but it's so frustrating to see these forms come in and it's missing a birth date, or it's missing a first name, or things of that nature. It's also important to make sure that who's ever preparing these requests, and that goes back to the whole concept of having maybe a dedicated person or a team who does this, making sure that that person or persons really understand what we're talking about here, that they're not trying to fill in a form that they really are not familiar with or don't understand the clinical issue, because that obviously will go a long way to making sure that you're able to communicate to the payer what it is you're asking for and what the patient's basic request is. I would say it's also important to learn from your errors. If you get a form sent back, even if you get a denial, try and find out why was that sent back. And usually the payer will be very clear about, what was missing or where the deficit was, rather than react in a negative way. And I understand exactly the feelings that practices will have around that. It's also a learning opportunity of how you can prevent this in the future. I would tell you at this point in time, our denial rate for ophthalmology is extremely low. I mean, literally low single digits, because again, ophthalmologists do this all the time. They understand their specialty, and they understand the requests that they're trying to make. And then I would also make sure that you're allowing sufficient time for processing. Plans certainly have the ability to deal with urgent requests, and we recognize that urgent requests will come up regularly. But at the same time, if you're a practice that is constantly sending in urgent requests, if the majority of your requests are coming in marked urgent, that becomes problematic. And in fact, that might actually flag a practice to be reviewed by a payer for whether or not they're aligning with the proper standard of care. So in a way, Darius, it really boils down to a lot of common sense, a lot of basic things, sort of the same thing you would do when you're preparing any important document or request. Make sure all the boxes are filled and all the information is there, and also making sure that you understand, whoever is preparing it rather understands what the actual request is, and do they have all of the criteria satisfied so that that request can be reviewed and approved as quickly as possible.
Derek, thanks a lot. The take-home message here for my audience and our audience here today is develop a streamlined pre-authorization process, have dedicated people, and most importantly, it's very rare to get access to a person like Derek who has long-term experience in this. What he's saying is do the electronic, invest in the time and effort to go online, because my suspicion is that if you're doing an electronic form, it will not allow you to not put the patient's name in, not their user ID number. Whereas if you're filling out a form, you fill out what you want to fill out, and you send it in, and then it goes back and forth, and there's unnecessary delays. Whereas if you're streamlined and you're all electronic, it's prompting you. We've all seen this when you're entering your credit card information and you forgot that little security code. So this is a great take-home message for me, and I'm going to go over that with my practice when I get back. Thank you guys for watching, and I hope you found this instructional and helpful.